Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Bruce Lin. Dr. Lin received his Bachelor of Arts in Biology and Computer Science at Goshen College in Goshen, Indiana. He studied medicine at the University of Vermont Medical School, receiving his medical degree in 1995. This was followed by a transitional medicine internship and a residency in diagnostic radiology at the University of Chicago Hospitals in Chicago, Illinois. Dr. Lin then did a fellowship in vascular and interventional radiology. He was the director of interventional radiology for Rush Copley Medical Center in Illinois, and then at Salinas Valley Radiology in Salinas, California. Dr. Lin joined the Washington Radiologist Medical Group in April of 2008. He is board certified in radiology with advanced qualifications in vascular and interventional radiology.
Thanks for coming. My name is Bruce Lin. I'm one of the interventional radiologists here. Actually, I'm the only one here. So how many of you know what an interventional radiologist is? I'm always curious. Anyone ever heard of interventional radiology or what an interventional radiologist is? Interventional radiology. Nobody knows what it is, so I better explain that before I move on to explain what are the treatments we offer. It is a very specialized medical specialty. It's actually recognized just last year by the American Board of Medical Specialties. It used to be under the general radiology umbrella, but now we've separated ourselves into a separate specialty. And so we are actually fellowship trained, board certified physicians who specialize in imaging, and in particular the imaging guided procedures. That means that not only do we read X-rays, CAT scans, ultrasounds, MRIs, like you frequently think of what radiologists do, not the technologists that take the films, but actually we interpret them. But we also use that information and use that technology to guide us to deliver the treatments. Okay, so some of the things that we're going to be talking about today are completely imaging guided procedures, so that we know where to go with that needle and with the therapy that we need to deliver. Okay, so our goal is to use the imaging guided, and it's a minimally invasive procedure because we do not perform surgery. We try to avoid surgery by using needles and small tools to accomplish what used to be done by surgery years ago. Okay. So the things that we do, just to let you know what interventional radiologists do. There are many service lines. We call them service lines, the areas of the body. We touch everything from the head all the way to the toe, and almost every organ. And some of the major ones, as you can see here, one is vascular. So if you have clogged arteries, peripheral vascular disease, if you have clots in your veins, if you have varicosities or problems with the arteries supplying your kidneys or your intestines, so you have pain or high blood pressure, those are the things that we typically treat. Actually, interventional radiology started as the specialty that treated those diseases. And then we evolved. And so now we're very involved in the musculoskeletal area, meaning back pain treatments, compression fractures, chronic back pains, even the tendon pains, joint pains. We offer treatments on those, pathology and areas as well. And then oncology. So that's one of the newer things that you may have heard about for IRs, is that we offer local regional treatments for cancers. So say if you have cancer in the liver or in the kidney, that we're able to actually treat that cancer locally and not systemically. We use little tools to actually treat that cancer called embolizations, plugging the arteries, stopping the blood flow, or we insert a little needle in there and we basically cook it. We kill the tumors by cooking it or freezing it. Okay, that's called ablation. And of course, then in women's health, we treat the fibroids by, again, embolizing them, taking away the blood supply. We treat the pelvic congestion, which is the varicosities of the veins in the pelvis, and a variety of other things. So, and all the other organs like the biliary stuff, the kidneys, urine, and just about anything you can think of that requires plumbing, we're able to, if we can get a needle there, we're able to, and get imaging there, we're able to treat that, okay? So that's what interventional radiologists do. We treat these disease entities using imaging guidance and by using micro tools to get there without an incision, okay? So that said, back pain, okay? So how many of you here have back pain problem right now? Okay, so you're at the right place, right talk, I guess. Back pain is a very difficult topic to talk about because it involves so many things, and it is very difficult to diagnose and pinpoint. It has a spectrum from the acute pain all the way to the chronic pain, and a lot of people live with back pain. The prevalence is incredible, okay? And so we can talk about back pain based on the location, meaning the bone itself in the spine, so these bones here. But if you look at the spine, it's not just a bone, right? So it's got discs, which are the little cushions in between the bones. You have the facets in the back, which are the joints that articulate the pieces of the bones together. Then you have the holes where the nerve roots come out, okay? And then you have the sacrum down here. And then you have all the muscles that wrap around the bone that can contribute to that. So there are many things that can cause back pain from the top to the bottom, okay? And this is why it's so difficult sometimes to deal with back pain, because you have to find out exactly what's causing it, where it's at. It could be related to just osteoporosis, which affects a lot of women and men to a certain extent, from disc problems, from trauma, from falls and car accidents and whatnot, and it could be from cancer as well, okay? So osteoporosis, this is probably by far the most common thing we see. So what you see here is electron microscopy images of normal bone. These are called trabeculae. You can see the density, the buildup of that. You can see what osteoporosis does to it. So it certainly will weaken the structure of the bone, okay? And this is another image of that. You can see the difference, okay? So this is essentially, the definition. It's a skeletal disorder that's characterized by compromised bone strength. So the strength of the bone is, when it's denser, it's going to be stronger. And as you can see, there are many holes in there. That means you're losing the mineralization in the trabeculae. It becomes weaker, and that predisposes you to a variety of conditions, and one of which is fracture, which can lead to acute and chronic pain. So osteoporosis, it's really actually an epidemic, as we mentioned before. 10 million Americans are affected by this, okay? So 50% of people age 50 years and older are affected by that. So we're obviously underdiagnosing it. We don't know the extent of the disease. And because of this, we'll have osteoporotic fractures, not just in the spine, but hips, okay? And even in other joints, upper extremities. And we usually underdiagnose that, and we overlook the significance of that because we don't treat that aggressively, okay? So in today's particular talk, I'm going to focus more on the osteoporosis and how it affects the spine, okay? So if you look at this chart here, you can see, here's male and female, you can see the bone density, okay, the bone mass. You can see the curvature of that. You can see how osteoporotic you can get by the time as you age, okay? So you peak, and then you basically become extremely osteoporotic, okay? So where we're seeing people mostly is right around here. So in this range, okay, I'm seeing most of my people, but I have a lot of patients are also right in this range. Okay, so we talked about the VCF, the vertebral compression fractures. So what is that? What happens to it? So a lot of times I see patients that come in, they have really bad pain, and when I ask them, usually there's a trigger for that pain. And when you look at the imaging, you see that it is the bone that's been affected. It's basically fractured. It's been fractured because of the compression of the axial loading force, from top to bottom, okay? And if your bone is not very strong, what's gonna happen is that if you look at the normal vertebral body right here, and you look at how it's compressed there, and you're gonna usually have some fracture plane that's horizontal or vertical or a combination of that. And it can be a result of a variety of things, activities that you do. It could be from just sitting down. We have patients who sat down on the toilet and had a fracture, reaching for something above or turning to reach for something, bending over to pick up something. Okay, it could be as simple as coughing or just nothing. They don't recall why they had this fracture. The pain just started and then just progressed and progressed and it got worse, okay? And the fracture pain can be very, very debilitating. They compromise what we call the ADLs, the activities of daily living. Things like cooking, walking, sitting, dressing yourself, toileting, these are things that can be impaired because you have such bad pain along the spine from that fracture, okay? And if you don't treat it, eventually, in the old days, it'll just kind of heal over time. It takes quite a few months. But what happens is that some of these fractures will evolve into other problems, and we'll talk about those. Okay, so they can have long-term sequelae and comorbidities, okay? So I'm sure you've seen people like this where as they age, they start to walk kind of hunched over like that, and they're unable to really straighten themselves, okay? And this is because of multiple compression fractures in the spine. So if you can imagine that spine having multiple fractures, eventually it's going to angulate. The biomechanics is going to change. In the old days, we really didn't have treatments that can heal that sooner. And so as each bone fractures, the other one goes with it, and it's a sort of a dominoes effect, and eventually you have a spine that looks kind of like that. And so this could be because, again, from just osteoporosis, which is probably the most common, or it could be from cancer, that weakened the bone, or sometimes from a trauma, okay? So this is an MRI of when you saw that picture of the person hunched over, if you took an MRI of that, this is what it may look like. This is the thoracic spine, we call it, this is in the upper back here, the 12 vertebral bodies in the thoracic spine. So you have the cervical spine that's in the neck, okay? And you have thoracic spine, that's sort of kind of the chest area, 12 of them usually, and then 5 down here in the lumbar spine, okay? Then you have the sacrum, okay? So this MRI image is of the thoracolumbar spine. And you can see the spinal cord is this little long thing right here, okay? And you can see fractures, multiple of them, right? And so of these, as you have one fracture, your risk of the second fracture is much, much higher. And you can see that this particular level where the arrow is pointing to in this particular sequence here on this right hand. So you can see that it's a little bit brighter, right? That bone that stands out, that's because of this swelling, the edema, the swelling and inflammation that's in that little piece of bone that's here. You can actually see a little crack over here, that little black line there in the middle of the bone. So that's the most acute, the most recent fracture. But all these other ones, these are all fractures, even up here. You can see that. So obviously, when you have a stack of bones that are fractured and are wedged like that, like a triangle, the spine is going to start to bend, okay? So that's what happens if we don't treat some of these fractures. And they'll heal, the pain will go away, but it changes the biomechanics and the contour of the spine, which can put more force and loading right in this segment here, from here to here, and this is why you're starting to see more fractures here, okay? And one will lead to the other. Okay, so the different types of fractures, okay, and these could be old, which can give you chronic pain, but at some point they were acute, and you may or may not have known that you had an acute fracture, and as time evolved, they become chronic fractures that may continue to give you pain, okay? So this is the wedge fracture that we saw on the MRI, okay? So if you go back, see, you can see a wedge fracture right up here, okay? And then you see the biconcave fracture. And if you go back, you see that's a biconcave, that's a classic biconcave right there, okay? And then you have a crush fracture. And sometimes these crush fractures can be really severe to the point where you lost almost completely the entire height of the vertebral body. You're almost flat, okay? And these are what the x-rays look like. And so people ask, well, how do you know you have a fracture, a compression fracture? So the quickest way to look at it, obviously, is an x-ray. Take an x-ray, you see that the shape of the bone has changed, okay? And so that may, and if that correlates with where you have pain, then usually, to a certain extent, especially in physical examination, it may be contributing to your back pain, okay? So, this is a kind of a wedge fracture. You can see, we call the upper portion, here's the upper end plate. It's kind of crushed down. You can see a little cavity there, okay? This is another bad wedge fracture. You can tell that this is almost like crushed, right? It's almost flat, okay? So, and it's got what we call kind of a scarring there now. So that's a more chronic fracture. That's been there for a long time, but because of this, most likely it led to that. Because now this is weaker, that bone and this bone, they have to carry a little bit more load for this bone. So we tend to see fractures adjacent to each other because of that. It's purely biomechanics, okay? So if we don't treat one, it can lead to other fractures. Here's another classic wedge-shaped fracture. And so if I were to treat this one, or if we don't treat this one, if I were to predict what is the next level that's going to break, most likely here, okay? Because now you have a change in the shape of the spine and the contour, so the distribution of the force and the weight might be a little bit different. Now this one looks a little funny, right? So if you look at it, it's a little bit more intense than, a little bit more complex than the other ones. You can see a subtle fracture line kind of straight down the middle. You can see that lucency there. And it just doesn't look as good as that one, right? So this actually has cancer in that. So that's a pathologic fracture. There's cancer in there that actually took away some of the normal integrity of the bone, just like osteoporosis did, so it's weaker. Okay, so where are these fractures typically located? So if you look at the spine here, most common, we're in this thoracic area here, T7, T8, but also at the thoracolumbar junction, okay? So if you look at the model over here, could be somewhere up here, okay, the curvature. So if this were, up here, okay, and also thoracolumbar junction down here, okay? You can see because that's where the curvatures are, okay, and that's where the weight, the greater weight bearing points tend to be, okay? All right, so how do people present with these? How do I see them? So typically, they come in when it's acute, okay? So, but not always, because when you have a pain in the back that you think it might be a muscle sprain, you tend to wait a little bit, but it'll gradually progress. And so usually with compression fracture, if you know that you fell and the pain is really severe and got triggered by the fall, you will seek help because you know you probably broke something. But if you didn't do anything, if you didn't realize it was just because you were coughing or you were reaching for something or you were bending, bending down to pick up something small, or even just sitting down, you typically will kind of let that go until you reach a point, it's becoming a nuisance, and then it becomes more of a chronic pain. By then, the X-ray changes will be very different. Okay, so in the acute phase, when they come in, we're typically able to diagnose that pain fairly rapidly because we know the cause of it and the location of that, and we can get imaging and treat that right away. But people forget that there are certain things that they do can also cause fractures, like coughing and sneezing, okay? And typically the course of it is that it may improve a little bit with pain medication, and it'll just continue to get worse before it'll get better, or they'll become chronic. It'll just always be bad, okay? And sometimes it's associated with other kinds of pain, like sciatica pain, okay? Or pain coming around the sides. So why, it's my spine, why is it coming to the sides? These are all reasons for that, okay? But because they have these distributions from the nerves that are not focused directly on the spine itself. Okay, so MRI, as I showed you on the other one, this is probably the best way to diagnose a fracture, or especially something that's acute or something that's ongoing. It may have happened 3 months ago, but you continue to have pain. And this is the go-to imaging that we do, okay? If you're MRI candidate. Not everyone's MRI candidate, okay? You can look at all the vertebral bodies and right away you can pick out that this one is abnormal. You can see the crack in the front there, upper end plate, and you can see all this bright signal. That's all because of the swelling, that's still there. So this fracture actually occurred 4 months ago. So theoretically, it should have healed by then. But you see how swollen it still is. So the fact that people think that compression fractures are only acute pain, that is not true. Okay, it can evolve into very chronic pain as well. Okay, and we used to think that if we don't treat it within a certain period of time, that it's not going to respond to our treatment, and that is also false. We find that, at least in my experience, that some of these pains that persist, even though they're months out, if we treat them, it continues to help them to a certain extent. It may not be completely, but it does help. And so this is another one that you can see, wait a while, and turn into chronic pain. You can see that crack right down the middle. That white line there, that's actually fluid now. So that vertebral body is actually cracked in the middle and it's now filled with fluid. So now it's not so stable because now those two pieces may be moving a bit as you're moving your body. Okay, that's extremely painful. That will not heal on its own very well. And so usually that requires intervention. So what are some of the options for treating these compression fractures as part of the back pain, either acute or chronic or subacute? Okay, so like I said, we used to do this completely as a conservative or medical treatment only because we didn't really have good alternatives. And that basically entails bed rest, lots of narcotics, pain medication to heal and to help you deal with the pain along, and bracing, And we still do that. I think it's very appropriate for certain patients, for certain types of fractures, but it doesn't work for a lot of people because what it does is it takes too long to heal and we end up with other issues that's secondary to the fracture, like additional fractures on the level above it, level below it. We end up with disc problems because of that fracture. The disc starts to bulge out. You end up with associated sciatic pain. You end up with narcotic-induced problems like you sleep all the time, you're lethargic, you lose orientation, you just don't want to get out of bed, you really don't want to, you can't do any activities that you typically do. So that can lead to DVTs or blood clots, deep venous thrombosis, because you're not moving, you're in bed all the time, and so you build up clots in your veins, which can then go to the lungs, and that can be very fatal. That's PE. You can end up with bed ulcers, lung issues, end up with bad breathing problems. Your lung volume gets compromised. Your respiratory status gets compromised. And so, in some people, the traditional conservative medical management is appropriate, but in a lot of, I would say in the vast majority of people, the quality of life is so compromised that it is no longer the standard of care. Okay, so what do we do? What are the other options? And it used to be that they would do surgery for the bad fractures. The ones that can't tolerate the conservative management, they will have to go to surgery. But now we have this option of vertebral augmentation. Okay, so as a means, we augment that particular vertebral body, that bone. Okay, and this goes to the minimally invasive part of what we do. So instead of opening up the spine, we basically do this with a needle. Okay, so just to give you an idea as to what can happen with an acute fracture. So this is the first week of fracture. You can see it's barely compressed, right? It's hard to tell the difference between that one and maybe that one. Okay, it's mildly compressed at best. That's the right there. 8 weeks after that, so chronic pain now, because the pain never went away. It's starting to wedge down, okay, because the bone is weak, and you continue to exert force on it. We have to stand. You know, there's no way we're going to be in bed all the time, and so that force coming down this way and that way would continue to wedge it. And sometimes what will happen is that this back plate here can then pop out. And this is where the spinal cord lives, okay? And so 8 weeks after that, we get an MRI. You can see how bad that piece of bone looks compared to what it used to be here. Okay, so now you see the kyphosis. You see the angle starting to bend because of that angulation. Okay, so in this as this wedges more, then this angle becomes worse. And what do you think the next fracture will be? Right there, typically, either above it or below it, because now you're putting a lot of force right here, right on here, right in this direction. So that's part of the problem that we see is that we have one fracture, it heals, you get over that, but then it continues to evolve into additional problems, additional fractures. This is from Texas Back Institute, from one of the case reports that they reported, okay? So January 2003, it looks like that. That's an MRI. You see the wedge clearly, okay? A month later, you can see that it's starting to lose height some more. But the problem is not so much the height, but this piece in the back here. See, it's starting to bulge out. And see that long, dark thing there? That's your spinal cord. So now that fragment is now touching on the spinal cord, starting to give you core compression. And so at this point, you're going to have a lot of back pain. And then it may, and that still wasn't treated. I'm not sure why. And it may, that whole bone is now basically gone and extruded out the back. Now you have compression of the cord. See how the cord is now bent like that? Now you're going to have leg problems, weakness, you're going to have incontinence issues and a variety of other issues that come with it. This is probably this is the other extreme, okay? We don't see this all the time, it's rare, but just to illustrate what can happen with a compression fracture when it becomes chronic and continues to evolve. Okay, so what is it that we're trying to accomplish with this vertebral augmentation? Okay, there's two types of that. Very similar. One's vertebroplasty. You hear that name. The other one's kyphoplasty. So the augmentation started probably, I remember even when I was in training, probably 15 to 20 years back. Okay, they started doing the vertebroplasty. First case was down in France. They did it for hemangioma in the spine. What they did is they put a little bit of, it was so painful that they ended up putting a needle in the bone and filled it with some bone cement to make it stronger so it doesn't continue to lose height. Okay, so that's vertebroplasty. Basically, you put a needle in there and you put cement in there under X-ray guidance. And then later on, we developed kyphoplasty. And basically what that does is you use a balloon to create a space inside the bone. So once you get the needle in there, you put the balloon in there and it creates a little bit of a space. But with some fractures, you may actually be able to increase the height, so reduce that fracture a little bit. The goal is not to restore the height completely, because that rarely ever happens. And if you restore some height, that's a bonus. But the idea is that if you create that space there, then what this allows the cement to actually settle in more to the area that you think it's more concentrated, which is the middle portion of the vertebral body, and not to leak out to the side, which is what we don't want. Okay, so what are the goals of this procedure? One is to stabilize the fracture so it doesn't continue to collapse. Okay, so you prevent further collapse, like the other case I showed you. You try to restore some of that strength so that the biomechanics doesn't change so much that you induce fractures from other levels, additional levels. Okay, and by putting the cement in there, you're reducing the pain. And by doing so, you're improving the quality of life so that you're able to perform some of those ADLs that I talked about, the activities of daily living, dressing yourself, cooking for yourself, just sitting, walking, the routine stuff that we take for granted every day, okay? But it's not necessarily to restore the height. So, when I tell people this, some of the patients tell me, oh, so after this, I'm going to be taller. No, you're not going to be taller. We're not doing this to increase the height of the vertebral body. Basically, the main point is to restore the quality of life. That is very important, especially for the people who are, in living alone, they're older, they're unable to have help, and they need to do everything on their own. That quality of life is precious. We need to be able to address that so they don't continue to spiral down. Okay, so what we do is that under X-ray guidance, we take a needle and we come all the way into the bone that's fractured, like that. And once we get in there, then we insert a balloon, and sometimes we use the little curved trocar, and we just make a cavity. Okay, so if we can inflate the balloon to a certain extent, sometimes we're able to restore some of the height, but sometimes we just have to create a cavity. Then we take the balloon out, then we fill that with cement, bone cement, not the Home Depot cement. Okay, so it's a special kind of cement. So don't do this at home. So this is just a quick depiction of one of the kyphoplasty tools called Kyphon. Okay, this is an X-ray here. So we put needles into the back, okay, under X-ray guidance, obviously. So we go through the pedicles into the bone. You put the balloon in there. And then we deflate the balloon. And you have a cavity. So obviously the cavity is not going to be nicely shaped like that. It's just cartoons. And then we put the cement in there, okay? So that's the basic concept, okay? So what does it really look like? So the goal is to put cement in it. So the cement, after we mix it up, actually, I always think it looks like toothpaste, and it actually does. The consistency of it, it's a little bit thicker than the toothpaste, but it looks like it's white, and when we mix it up, we have a certain amount of time to deliver that. Once we put that into the bone on the X-ray guidance, the body heats it up, actually becomes rock hard. Becomes part of the bone, stays with you, integrates into the bone, and it's really, really hard, okay? And if you took a CAT scan of that, a cross-sectional CAT scan, okay, like slicing like a bread loaf like this is a vertebral body, this is a fractured vertebral body. You can see the cracks here, cracks there, cracks here, cracks here, okay? And here's the canal. This is where the spinal cord lives, right in here. So you don't want cement in that canal. This is why we do it on the X-ray. We don't want cement in there. And this is the pedicle, these areas. So actually, the needle comes from the back, like this, goes all the way into the bone, okay, and coming from here, and then create a cavity in there, and then we fill with cement slowly. And this is what it looks like after we fill it with cement, if we were to take an image of that. So we don't want the white stuff back here. You can see a crack right here, actually, a little step off there, right? So this is why we need to do this under imaging guidance, okay, so that we don't get cement in there. At the end, what do you end up with? You go home the same day. So usually, unless you come in you're already in the hospital, you're admitted to the emergency room because the pain is so bad. And over 50% of my patients are this way. They can't take it anymore with a conservative management. So they end up coming to the emergency room and being admitted to the hospital. Then we do this as as an inpatient while you're staying in the hospital. But most of them, we like to catch this early enough so that you're not, having to go through that whole system just to get treatment. So if you're an outpatient, I would see you in the clinic, we would determine what this is. We have the imaging to support it. We figure out this is what's causing your back pain. You come in the morning, we do the procedure, which takes about an hour or so. Then we have you rest for about 3 hours. And then you go home. And what do you expect to see at the end? These are the little needle holes in the back when it heals. So there's no incisions, okay, just needle holes, okay? And then we follow up in a couple weeks. So that's why we call it minimally invasive, because we try not to cut you open. We don't dice and slice. And so and some of the instructions afterwards is obviously you gotta be careful with what you do. And I spend a lot of time counseling the patients afterwards as to what they should and should not do. And they don't realize that most of them don't realize how much they're really overdoing in some of their daily activities. And so you have to be very mindful of every action that you do once you've gone through one compression fracture, because you're at much higher risk for a second one, okay? All right, I'll skip over that. So the idea is the relief. So if you ask me how soon do you get relief from the pain, it actually depends. My experience is that the more acute the fracture is, meaning that if you just broke it, say within a week or so, and I do the procedure, the relief tends to be sooner, tends to be a few days, and they experience quite a bit of relief. But after you wait a few weeks, a month, or even a few months, the recovery time, or the time from the procedure to reasonable pain relief, tends to be longer, sometimes out to 2 weeks. And if the efficacy also is lower, because you already have some scar tissue involved, you may also have some additional problems like disc disease involved by then. And so it tends not to be as effective as it would be with an acute fracture. That's just in general. There are always, odd cases and atypical cases, okay? Again, idea is to improve quality of life so that you can restore some of your daily routines, okay? It's not for any really other reason, but that is so important in this population. Okay, so other than this compression fracture in the spine, you can also have fractures in the sacrum. So the sacrum is this piece down here, okay? That triangular piece down there. It's right in the tailbone area, okay? And so the trauma, usually it's induced by trauma, like a fall, if you sat down too hard, and in addition to if you're very osteoporotic, in addition to the axial loading force that's on that spine, where you can compress the bone, you can actually crack that sacrum. And it would look something like that. Usually 2 vertical cracks down the side, and then a lot of times a horizontal one across the middle. So does anybody know? So we have a classic name for when we do a nuclear medicine bone scan for these patients that are really painful. Actually, it's very prominent. We see we call a Honda sign. It just lights up when you get an H, right smack in the middle of the sacrum, okay? And that we know that's a sacral fracture. Those are very difficult to deal with, okay? Because you see these little holes here? That's where the nerve roots come out of. We don't want cement in there. But a lot of times these fracture lines will go right through those holes, which means that if you put cement in there, it may actually leak into the hole. So these fractures are very difficult to manage. Sometimes we try to cement a little bit, like that. So we do it on the CAT scan. So this is sort of a pictorial, 3-dimensional way to look at how we treat it. Take a needle and go into the sacrum, the fracture is right here. And this is a CAT scan, okay? And this is down in the pelvis, so slicing horizontal like this, upside down, this is the buttock area, and that's the belly, okay? And you see one bone here, and one needle here, and one needle here. And the white stuff is the cement. And so the cracks are usually here, and then sometimes across the middle. So what we hope to accomplish is that just deliver a small amount of cement on both sides and the wings to stabilize those fractures. And you'd be amazed how much relief you get with just 1 cc of cement, which is not a whole lot. But that's how painful those fractures are. And that's because of osteoporosis. And a lot of people actually have sacral fractures and they just live with that. And so they can't sit, right? It's very painful. They can't really stand, they can't ambulate. So what do? They end up in bed with lots of narcotics. And over time, they lose orientation, they get confused, bed sores, clots in the veins, and it just really pushes them over the edge. Okay, so these are some of the sacral fractures are some of the very debilitating fractures that we deal with, and they become chronic pain syndromes. Okay, so we mentioned chronic pain. Okay, so obviously the compression fractures start out as an acute thing, and then they can evolve into chronic pain if untreated. But a lot of times we see chronic pain with other entities, not just compression fractures, right? So there could be something that's nerve-related, neuropathic, where it's nerve pinching. The classic one is sciatica. pain just shooting down the leg, all the way to the, could be to the knee, to the foot. Or sometimes it's just the buttock pain, just this annoying buttock pain. I just treated somebody this morning with that, just very annoying. It's hard to pinpoint where it's coming from, and it seems to move around all the time. Okay, I don't know if any one of you have that kind of a problem, where just really a pain in the butt that moves around all the time. Very hard to pinpoint. And sometimes it's because of the facets, those bone joints that I mentioned, or a variety of other things. So chronic pain is very difficult to deal with. But a lot of people suffer from that. Okay, so we're actually not treating the majority of the chronic pain. They're just on pain medication, and some of them just tough it out. Okay, and it continues to evolve. And you may have chronic pain from one disease entity, and by next year you have chronic pain from a second problem, because obviously everything is interrelated. They're all connected, right? And so if you have wear and tear on one and you don't take care of it, it can cause the second thing to have to pick up the slack, and that second entity will end up with inflammation and pain as well. So it just spirals down. Okay, so how do we usually evaluate this pain? What do we ask you? These are the things that when you go see a doctor and you have pain in your back and it's chronic, be it chronic or acute, okay, the things that you should think about to tell the physician is it acute or chronic, meaning how long have you had this pain, okay? Is it axial peripheral, meaning is the pain down the middle, or is it pain going down to the legs, or maybe even to the arms, if we're talking about the cervical spine, okay? Or does it come around the side, okay? So that makes a difference as to whether it's axial or it's a peripheral, okay? And what makes it worse? What kind of activities make it worse? And what makes it better? And that may also give us a lot of clues as to what area to target and what kind of imaging to order. Is there a radicular component? Radicular meaning sort of a shooting distribution, like sciatica. Okay, so that's a radicular pain. It goes from the back all the way shooting down the leg. That's a radicular component. Okay, and how impaired are your activities of daily living? Okay, what can you walk? Can you sit? How long can you sit? That kind of thing. And what are some of the associated symptoms? So if you come in and tell me, I'm losing control of my bladder ever since this happened, that's really bad. That points to a cord compromise. Okay, not just a sensory pain, and not just a motor pain. If you have lower extremity, like leg weakness, I can't walk anymore ever since this happened, that's also concerning because you're losing that motor strength. But when you start to say I have some neurogenic problems, then we're thinking about that central nervous system that really warrants different kind of interrogation and imaging. Okay, and if you have prior surgeries, what does that matter? Because if you have spine surgery in the past or injections, you could have things like infections in there. Okay, you can have scar tissue from the back surgery, which can really grow out of control and end up with nerve impingement. It can give you sciatica. When it was done for sciatica in the first place, it may get some relief and then it come back because the scar tissue has sort of kind of grown out of control. Okay. So this is disc, obviously. A disc is that little soft cushion between the two bones. Okay. So you all hear about disc herniations, disc bulging. That disc is integral to our spine. If we don't have disc, we just have this bone grinding on bone, and you will be in a lot of pain. Okay, so disc is important. It's soft. When you were young, the disc is thick. It's soft. It's got a what we call an annulus around it, which is a very, very thick and strong fiber. And then in the middle is kind of a pulp. It's soft, like a gel. So think of it like a jelly donut. Okay, so if you squish the inside and the jelly pops out, where's that jelly going to go? Most of the time it's going to go towards the back, where the nerve roots and the spinal cord is. And so you're going to have a disc herniation, and that is going to cause pain because it's going to pinch on the nerve root. It doesn't always happen in the midline, right? So this is a MRI of a disc herniation. You can see where the disc is herniated, right? Here's a normal disc. It's nice in terms of shapes. It's thick. It's not coming out the back. And you look at this one, it's dark, meaning it's desiccated, it's dried up, okay? It's lost the normal integrity of that. And not only that, it probably has a defect on the back and it's popped out. You see that disc herniation that's back there. And if you look at the cross-section, you're gonna see that fragment there. See this thing here? It's pinching on this black thing, which is where all the nerve roots live. So you can see how painful that could be if you have a nerve root pinched over there, okay? And if you look at it, it can be not just in the middle, but also to the side. So now it's hurting out the side, it's pinching on the nerves, okay? And it's creating a lot of inflammation. That's what gives you the sciatica, okay? That sciatic pain that shoots down the leg, and every level of your body, every level of the spine has a specific, what we call dermatomal distribution. So every pair of nerve root, they innervate a certain part of the body. And so that's why when you say my pain is all the way down to the foot or to the knee, we can usually tell that's L4, that's L5, that's L3, a combination of that. Because if you look at these color-coded areas, you can see, some of these L5, you see S1 here, L4, L3. So they all have assigned territories so that we can tell what's being affected, okay? And that's the radiculopathy that we talked about, okay? If you have a disc problem that's affecting one side or both sides, you can sort of kind of pinpoint the level. And then you correlate that with the imaging. So this is the normal spine, very nice looking. The bone, vertebral bodies, those bones, little pieces of bones are nicely shaped, squares or rectangles. The height's good. You look at the discs in between, nice and thick. The signals are all the same, right? That's what a young spine looks like, okay? As we age, we're gonna end up with this kind of spine, where you're going to see how the discs are flat, it's desiccated, dried up, really not good looking, and it bulges out the back. You can see that, right? Along with the little pieces of bone, little spurs. So now you have not just the disc, but you have little pieces of bone with the disc. So now you have what we call a disc osteophyte complex. So now that's really going to hurt, okay, because it's not just something soft anymore, okay? And that causes that canal to narrow. You see how wide open that canal is from bone to bone? And see how narrow from here to here, okay? So that's spinal stenosis, okay? So if you heard the term, I have spinal stenosis, because that little round area where I showed you this round area here where the spinal cord lives, it is now being pinched from the disc coming this way, and also from the ligaments going that way. So now it's really small, okay? And so what happens? You're gonna have compression, you're gonna have pain, right? It's either going to be mid-back pain, low back pain, and or going down the legs. Both legs, one leg, maybe one, different types of distribution. So in those instances, obviously, if it's just a disc, surgery is good. We have minimally invasive surgeries that we can extract this fragment so that we can open up that space. We can cut the bones off on the back here. With minimally invasive techniques, we're fortunate to have really good spine and neurosurgeons here at Washington Hospital. I worked at hospitals from East Coast to Midwest to the West Coast, and we're very fortunate to have good spine and neurosurgeons here who can perform these minimally invasive surgeries to alleviate that mechanical pain, right? After all, it is an extra piece of something that ought not to be there. So it's a mechanical problem that is a root cause. So you want to resolve that. But some people aren't surgical candidates. They just can't go through surgery, or they already have one surgery, and it's too much scar tissue, you don't want to do it again. For whatever reason, if you can't do surgery anymore, and these aren't surgical candidates, or you're too afraid to do surgery, or the impingement, that problem is not so severe that it warrants surgery yet, there's something called epidural injection how many of you have epidural injections in the past? Probably several. Okay, all right. So basically what it is, it's delivering a cocktail of medications, including anesthetic, short but fast-acting anesthetic, okay, and some anti-inflammatory drugs and some cortisone. into the epidural space, which is the space that surrounds the spinal cord and the nerve roots. So that little space there, that's the epidural space. That space there where the tip of the needle is, right there, that's the epidural space. It's a very, very small space. And so we need the imaging guidance. Here we go back again to the imaging guidance, the importance of that, to deliver that needle to that tiny space in order to be to do a targeted delivery of drug. You can do epidurals at multiple levels. You can give it to the left, to the right, in the middle. But if you are just giving it without imaging guidance and you don't and without really correlating with an MRI or something that tells you what the pathology is, it's not going to be useful. You're going to have an epidural injection. You're going to go, well, it lasted like 2 hours, 3 days, and the pain's back. It wasn't useful. And sometimes it isn't. Sometimes the pathology is so bad that the impingement and the inflammation is so bad that it's just not going to be very durable. But many times it's because, if you don't deliver it to the right place, it's not going to be that effective. That durability is going to be short, right? And the efficacy is not going to be 70, 80% effective. It's going to be like 10, 20% effective only, okay? So that's why the imaging portion is so important. First, to identify what the problem is, what the problem is, and if it's appropriate for epidural injection. And once we know that epidural injection may help, we have to specifically target that area. It may mean that we go to the left or to the right or down the middle, but we have to know, okay? And so this is a depiction of going down to the middle, but you can also give it to the side, to the left, to the right, okay? So that's an epidural injection. And if you ask me, if you never had it, and you ask me, well, how long is this going to last for me? Well, first of all, it's not forever, right? Because as you know, the root problem is the mechanical issue. You still have whatever that caused the pain. If we haven't resolved that, then the pain will always come back. But I always tell my patients that the first shot is almost as diagnostic as it is therapeutic, meaning that if it didn't work at all, probably that's not the right level. Either we didn't do it right or that's not the right place, right problem. And more likely than that is because that's not really the cause of pain or not the main cause of pain, okay? And so it can be therapeutic and diagnostic at the same time, the first injection. And once we get some results, we know that we can continue to deliver that if we have to. So how often can we do this? I try not to give it longer, more frequent than 3 to 4 months. If it's really bad pain, we may do that. But what I find is that the more injections I give, the effect is not as good as the first few. So it gradually loses that effectiveness. Okay. Then the other portion of the spine that can give you pain are the facet joints. Okay. So the facet joints are these little small joints between these vertebral bodies. So from one level to the other, they have to articulate. They have to join, right? They have to be able to push on the other. So these are the facet joints. These little joints here. So there's 2 on top, 2 at the bottom for every vertebral body, okay? And they have, as you imagine, when we stretch and bend, okay, flex and bend and extend, you're going to exert a lot of the stress on those facet joints, okay? So that can be a problem. They can become arthritic, and they can become inflamed, and they can cause a lot of pain in addition to this problem. And a lot of times, they come as a secondary thing. You have compression fracture, and as a result of that, you're kind of adjusting to it, and you're straining the facets, and you get facet pain, facet hypertrophy, meaning like really gnarly, bone spurs grow because you're really grinding that. You're just trying to adjust your body to the pain. They can be secondary problems. So this is an MRI of what that facet problem can be. Two different kinds of facet problem. One is here. So this is the facet looking at it, that's looking at it this way, okay? So that's the facet between these 2 vertebral bodies. So they usually have a little nice disc in their little synovial joint that's lubricated and works really well. As we age, we lose that nice lubrication, and if it becomes like any arthritis, it's bone on bone, okay? You lose the synovial lining there, and then you can get fluid in there like that, where it's inflamed, or you can develop all these really bad looking bone spurs, right? That looks really ugly, right? So you don't want the facet to look like that. And as a result of that, you see there's a little ligament there, which is a thick kind of a attachment there to connect one bone to the other. They get thicker in order to compensate for this. And then you look at this canal, so it's narrowed, right? The shape is odd. It's not a nice and round shape anymore. And then the nerve roots come out the side here. So you don't longer see a nice canal there. It's bone on bone, bone on disc, actually, okay? So now you're gonna have sciatic problems, partly because of the facet issue contributing to that, not only the disc. And this disc, in this case, actually is already bulging. You can see the asymmetry on this side versus that side, right? It's bulging out that side. So in any given level, you can have multiple coexisting problems, and probably started out as one and then led to other issues. And then you have to tease them out one by one and treat them separately and differently, okay? And so how do we treat these facet problems? The simplest way is just to give it another injection, just like epidural injection. If it's truly the facet problem, and we identify by imaging, like MRI and correlated with the physical examination, we know that's where it hurts. And it's very difficult to pinpoint that. A lot of times we end up treating with epidural first, treating with other things first, and then figure out, well, nothing helps, probably a facet issue. And the imaging correlates with that, then okay, we're going to tackle the facet. And that's the facet there. You can see, we call it this is a Scotty dog. You can see the head, the ear, the little legs, see that? So there's one dog on top of the other, and you see the little space in between. That's the facet. That's that little white thing there. That's the articulating facet between the two levels, okay? So we look at that under X-ray. So here goes the need for imaging guidance, right? We take a needle and we just go straight down into the facet, okay? And we dock it in there and we deliver the same, similar cocktail, basically cortisone and some anesthetic, and we try to numb that area up. So again, we're trying to alleviate the symptoms, but in terms of durability, how long does this last? It's hard to say. Truly that is a facet problem. It may be very effective, but again, it may be short lasting, or it may actually last as long as a year or two. I've seen the whole spectrum. So if we do multiple facet injections, we do it once and it seems to work. 6 months later, it comes back, we do another one, and it seems to work. So we know that facet is a problem. Sometimes people will take the next step. We do something called rhizotomy, where there is what we call a median nerve, which wraps around the facet like that, okay? So if you look at it in it's kind of a cross-sectional slice like this, okay, you see here's the disc, here's the canal, so this is the back, and that's the belly front there, okay? And here are the facets, right? And these are the muscles. And so here's a spinal cord, and these are the nerve roots coming out. So if the disc bulges out this way, that's going to pinch on the little nerve roots there. See the rootlets there? Bulges out that way, it's going to pinch on that nerve root there. Bulges out, it's going to do that. Sometimes you're going to have facet problem. We inject that. The epidural comes in that area. Okay, if you have compression fracture, we treat that. If there's a disc herniation, a little piece there, they can come in here and they can try to extract that out by minimally invasive techniques. Take that out. This is that annulus. That's that thick ligament that I told you about that makes up the outer part of the disc, and this is the filling of that jelly donut right here. So this is usually, there's a break in here and this pops out, a break in here and that pops out. Okay, that's the disc herniation. So if we do the facet injections, okay, and they work, but they don't last, there's this median nerve branch that comes around here, and they innervate the facet. This is what feeds that pain. Okay, that's a sensory component, not the motor component, but the sensory component. Then we can take a little needle and that is hooked up to a generator, a radio frequency generator. Okay, so it's kind of like a microwave. So you put a needle in there, you hook it up, and you deliver that radio frequency energy, and in essence, you kind of burn that nerve. So you destroy that nerve tissue, so it can no longer provide this pain feedback to your brain. So there's no nerve there, it's gone, I don't feel the pain, okay? Sometimes it will come back. Sometimes it will. Our body is very incredible. We have regenerative ability. Sometimes that can come back and we can have recurrent pain. But typically, it has a much longer lasting, effect than just a facet injection. So if we treat the facets a few times and we know that that's where the problem is, but it's not durable, sometimes we'll do that. Okay. But again, diagnosing the facet pain can be very difficult. This is part of the chronic pain syndrome that can start with a compression fracture or just with a disc herniation. Okay, so if sometimes we do everything. Okay, we treat the compression fracture, we treat the disc, epidural injections, we do the facets, and still they have pain. And it's not as uncommon as you think. There are patients who just have this chronic back pain that after years and years, nothing seems to help. Okay, so if I treated epidural injections and it was good in the beginning, but the durability is shorter and shorter, and it's no longer as effective, sometimes what we'll do a neurostimulator trial. Okay, so what it is are two leads, usually two. Sometimes you can put one in there. They go into the epidural space that I told you about. So they'll come in right around here. Under X-ray, we put a little needle in there, and we thread the little leads inside the epidural space all the way up here. Okay, so under that bony roof here. Okay, so we thread that up there, and these leads have little tiny electrodes. So usually 8 to 1. So now you have a pair. Okay, next to each other. We try to put them on the back of the space and close to each other. And then the leads on the outside part is hooked up to a little tiny little module. And that module is programmable. So we can program these little tiny signals that go up to the leads. And that signal actually produces a little numbing sensation. Okay? So it replaces the pain sensation with a sort of a numbing sensation. And we can adjust the height and the intensity of that strength of that signal in order to match where your pain is. So sometimes you need it in the lower back, and then a little bit more in the buttocks, maybe a little bit more in the thigh or lower, or so we can adjust it by activating and deactivating different points of the stimulator, and only one side stronger or the other side stronger, we can adjust the laterality of that. So it's proven to be actually helpful for people who have chronic pain. Just nothing seems to help. So what I do is I would put these leads in, I'll leave them in, and we'll hook it up to a remote control so that we tape it, and then you have this remote control. You can turn it on, turn it off, adjust the strength and the level, and you go home for a week with that as a trial. And you try it at home. You can turn it on and off and adjust it. After a week, if you think that that was really helpful, that really took care of my pain, really helped. It was better than having that pain. It might be sort of kind of odd in the beginning because it feels kind of numb, but at least replace that awful pain sensation that prevented me to perform my daily activities. So if that is something that's helpful, then we would take the leads out, then we would arrange for permanent implantation. So this module here then will be implanted under the skin, usually in the back here, okay, under the skin or the buttock area, and it will be connected to the new leads that will be inserted to the level that we had predetermined to be useful, okay? And then we can adjust, then you have a control that you can reprogram as your symptoms change, okay? So that's a neuromodulation, neurostimulator. That's another option that we can offer for people who have just chronic back pain that fail multiple other modalities. And so this is that trial I talked about. So we insert it up here. You can have these leads, and they're able to adjust it and reprogram that, okay? And then the other one is just basically delivering drugs, okay? So you need pain medication. You don't want to, taking it orally, it has a lot of side effects. You have to wait for it. You're groggy all the time, lethargic, and gives you constipation sometimes and all the other problems. So people came up with the idea of, well, why not just like a epidural injection, epidural anesthesia, or intrathecal. So they would put these little tiny tubes into the intrathecal space where the cord and the nerve roots are. We implant that, and it's connected to a pump, okay, which is also under the skin, and we load it with medication, with narcotic, be it morphine or whatever else that works for you. We can adjust the dose, and it just gives you this little dosages, the automatic pumps that give you a little bit of a medication as you need it at a specific interval and a specific strength. Okay, so for some people that seems to be the solution. With people with really debilitating chronic pain that nothing else works. They end up with a targeted drug delivery at the level that they need, because every level of the spinal cord innervates a different area, right? So depending on where your pain is, you have to target that level, okay? So that's the systemic dosing. I mean, that's the targeted drug delivery versus the systemic dosing where you're just taking pills, getting an IV, it goes all over your body. Okay, so that is sort of kind of, for me, I reserve it as the sort of the last option for people with severe chronic back pain, but we may have to resort to that. Okay, and again, we do that with a trial. So we put that little tube in there. We do a little trial, see if it works for you. If it has too many side effects and you don't like it, it doesn't quite work, or doesn't treat the pain sufficiently, we don't implant it, all right? And this is some of the programmable pumps that are available. It can look like that. It can be reprogrammed, just on the outside. So there's a lot of studies and evidences that, obviously this helps. And a lot of people walking around with these stimulators and pumps. Ultimately, my personal opinion is that if we can try to avoid that, that would be the best. If we can sort of kind of treat the symptoms with minimally invasive options, either injection or then moving on to just enough so that you're able to progress to physical therapy and build your strength, basically core strengthening to recondition you, because once you have back pain, you're basically deconditioned. Your muscles are not being used, they're getting atrophy, and that goes into a cycle where muscles are weaker, so you're using your bone more, and it gets worse. So physical therapy is a very important component. Once we get you over that acute phase of pain, and you're able to tolerate some physical therapy, we get you plugged into the system, and you need to mentally encourage yourself to do that, because ultimately, you don't want to have to continue to get injections or, other treatments in order to combat this chronic pain. At the end, if nothing works and you're unable to do physical therapy and nothing works, then that's where we go to, neurostims and pumps, okay? So that's sort of a spectrum of things that we do. Of course, there are other things like, there are muscles in that area, like a piriformis muscle injection, where the muscle goes from, the sacrum to the hip, and you get this deep buttock pain, and it pinches the sciatic nerve, right? So even though it's not bone, the muscle is tied to the bone, and it's causing that pinching of the nerve, and it simulates the sciatica that you would have, okay? So that is also treated with injection. We have to target it with ultrasound and deliver the drug to exactly where it's at. And there are a variety of other, entities, but it's too many to mention. So at this point, I think, you kind of get an idea as to what are some of the options available, and what are some of the causes for the pain, so that you're a little bit more aware of how to bring yourself to the necessary healthcare provider to get help, okay?